Hello, everyone. My name is Dr. Fergal Armstrong, and welcome to Cracking Addiction. And we have with us Dr. Richard Bradlow. So, Rich, I thought we'd do a deep dive into the effect of substances on sleep architecture, because we're both passionate in regards to our commitment to giving people a good night's sleep. And because we both work in the addiction space, we need to be aware of how substances that are misused can affect sleep.
Thank you very much
So
for
what are
having
your
me on, Fergal. Sorry.
yeah?
Sorry,
So
go on. Sorry to interrupt.
no, I was going to say do you share a commitment to sleep?
I do. I think one of the tricky parts about working in the substance use medicine is that, especially in that post-withdrawal phase, what we see is a sort of a prolonged sort of insomnia sort of withdrawal phase to a lot of different substances. Cannabis, to me, is the biggest one. And so I think a lot of your work in addiction medicine is taken up by managing insomnia. And then also a lot of people, I would say the two most common reasons in my clients that have led that they've identified as having led to their addiction would be insomnia or social anxiety. So a lot of my clinical practice is on managing insomnia for sure.
Exactly. Insomnia is a risk factor for substance use, and also, in my experience, is a risk factor for relapse. And if clinicians fail to understand the risk of relapse associated with insomnia and they dismiss insomnia, well, they do that at their peril and also to the peril of their patients. Here's a question though. How do you manage post-detox insomnia?
Yeah, it's really tricky. This was actually asked to me by some GPs I was chatting to last week, and I'm going to say what I said to them, which is I do the exact same way that I advise to manage insomnia in anyone, which is I focus on lifestyle changes and I discuss with them the difficulties in medicating insomnia and the difficulties in that we are always going to be chasing our tail here, and I don't want to replace one substance with another. And then eventually I break and I provide some sort of short-term medication relief in that post-acute detox period with the very clear explanation and plan that this is a short-term plan.
So what do you do? What do you prescribe? So let's say someone's finished a detox off, I don't know, methamphetamine, right? Or even alcohol, and they're out of hospital. What do you prescribe if you are going to prescribe something, and for how long are you going to prescribe it?
Yeah, well, so what I will prescribe is actually dependent on the patient because I'm a big patient information advocate, and I discuss the options, and they're usually low dose quetiapine or a low dose sedative antihistamine, or maybe even suvorexant, maybe low dose mirtazapine, and I'll have discussions with the patient about the pros and cons of these medications, or how they work, and then the patient will choose. And how long for? That again is a piece of string question. It depends on the patient and the frame, but I'm usually framing it as 2 to 4 weeks at the most.
Right. So we're talking about the use of antipsychotics at low dose and antihistamines or drugs with
Yeah,
an
and
inverse
and and
histamine
with the
reaction.
antipsychotics or the antidepressant, it's all just the histaminergic
Yeah.
uh, blockade that we're using,
Yeah.
rather than using, well, with suvorexant, so it's something
Yeah.
completely different. Uh, but uh, I'm generally avoiding benzodiazepines and GABAergic drugs, especially as these are patients who are very tolerant to GABAergic drugs. So obviously that's going to be a more tricky
So for the
scenario.
pharmacologists amongst us, mirtazapine is an inverse histamine agonist. It's not an antagonist, it's an inverse agonist. Nonetheless, sleeping tablets, be they quetiapine, mirtazapine, or sedative antihistamines, or for that matter, benzodiazepines. How effective are they?
Well, I think it comes down to what you're after. And I think what most people are after are trying to reduce sleep latency, right? When someone comes in and says they're suffering from insomnia, I think the vast majority of people are struggling with prolonged sleep latency. Some
And what is
people,
prolonged sleep latency?
yeah, so sorry, yeah, absolutely sorry, time it takes to get to sleep. Some people
Right.
are having sort of early morning rising or sleep or waking throughout the night, and that is actually a different kettle of fish. But for the purpose of answering this question briefly, I think people are talking about sleep latency. And in that case, sedative medications are an immediately acting drug that does reduce sleep latency. And I think that's really important. I think in my clinical practice, it is the drugs that are immediately acting that patients are asking for and believe are more effective than the drugs that aren't immediately acting.
Right. And in terms of, so we know that they're immediately acting, but by how much would a benzodiazepine reduce sleep latency?
Well, it depends on how much you take, but rather quickly.
Yeah. Right.
depends on depends on how much food you have in your belly, and depends on how you're ingesting the benzodiazepine, and depends on the dose of the benzodiazepine. If you're injecting clonazepam intravenously, it's going to reduce your sleep latency to the time it takes for it to kick in.
So the one brain arm circulation time,
Yeah, rather quickly.
which is about 20 seconds or yeah.
Yeah.
Anyway. All right. Okay. Okay. So we've talked about how insomnia is a trigger for substance use, a trigger for relapse. We've talked about how really your approach to this is look at sleep hygiene, which is a whole episode in and of itself, and then look at the use of short-term drugs that actually help with sleep latency. Let's move on to the effect of substances on sleep architecture. So, first of all, sleep architecture is not just sleep latency. What are the key elements for sleep architecture?
So, sleep architecture, sleep latency absolutely is one of the key elements. Sleep quality, and that can be measured in several different ways. But you want an ample amount of all the different sleep stages. You want a heavy loading of your deep sleep at the start of the night. You want a heavy loading of your REM sleep at the end of the night.
Okay, so there's two things we need to clarify. REM sleep, deep sleep. Talk to us about that.
There are three stages of sleep. There's deep sleep. This is front loaded, and it is where the brain is at its least active. There is a middle phase sleep, which is where you spend the majority of your sleep, and there's REM sleep with rapid eye movement sleep, and that's when you do your dreaming, and that's backloaded. Um, I'm sorry, I can't remember the whole question, but I think I've adequately answered it. Hopefully,
Yeah, yeah. So we're talking about when we're thinking about sleep architecture. I mean, there's various parameters, but we are really interested in sleep latency, slow wave sleep, deep sleep, and REM sleep.
and I think
Right.
there's a bit. It's one of those situations where there's a bit of a disconnect, which I think the most important thing for the patient is sleep latency. But I think for one of the most important things for the practitioner is really sleep quality and sleep architecture.
Yeah. Patients want to get to sleep quickly, but one of the things that I am very passionate about is protecting REM sleep because you mentioned that REM sleep is when we dream, but it's also when we process the events of the day. And if you can't process the events of the day, you wake up irritable, and you then have reduced resilience. You then have the inability to cope, which then leads to substance use, which then potentially ruins the next night's REM sleep and then creating a vicious cycle. Because a lot of substances reduce REM sleep. And
I
in
would say
particular,
basically every substance reduces REM sleep.
every substance, that's well,
With
every ketamine.
I'll give ketamine a pass.
We'll give ketamine a pass. Right. Okay. But apart from that, every substance has the potential to reduce REM sleep. So when we are dealing with distress, which is a driver for substance use, that same substance use is actually impeding our internal psychotherapist in our head from managing that distress. And for me, that is, as an addiction specialist, that for me is one of the key therapeutic targets. You've got to stop the deleterious effects of substances on REM sleep. Now, in detox, and we do that mostly by detox, but in detox, of course, when REM sleep is restored because the substance is no longer blocking it, it's not only just restored, but there is a rebound effect where you get sudden rebound in REM sleep. You get more REM sleep than usual. People complain of nightmares. I actually say to them that that's a sign that the detox is working. What do you think?
Not sure I'd put it so glibly with what I assume are patients with PTSD reporting a recurrence of their nightmares.
Well, that's a very good point as well. That's a very good point. So, what therapy can you institute in the detox phase of someone's recovery journey to help them with nightmares as a result of rebound REM?
In the detox phase?
Yeah, you could do it even in the detox phase.
Pharmacotherapy?
I would use, I would use prazosin even in the detox phase.
Yeah, I use or clonidine. Yeah, in the
Yeah.
It depends if it is PTSD related nightmares or it's just nightmares. But yeah, 100%.
Well, this is the thing. Even with nightmares, I think that clonidine and prazosin work even without the formal diagnosis of PTSD. Because what they do is they simply suppress.
Well, I'm a psychiatrist. If I say it's PTSD, that is the formal diagnosis.
Yes, but sadly, Richard,
by definition, they have PTSD.
But sadly, Richard, you are not omnipresent. You are omniscient, but you are not omnipresent, and so some patients have to rely on my care, not yours. So therefore, I would say that anyone with bad nightmares can get prazosin or clonidine to help them suppress the noradrenergic rush that is associated with nightmares. So you can still have vivid dreams, but if you're waking up distressed, I think that's an indication for prazosin or clonidine. But that's the REM sleep coming back, isn't it? And once you can get that stabilized, then you've got your internal psychotherapist helping you process all of the trauma of the day, all of the issues of the day, the fact that you want to punch your boss or deal with stress. Rather than resorting to your previous substance, you can then use your brain to process it. So we've agreed that all substances impede REM sleep. So what substances? When we say all, let's talk about the big ones.
Well, sure. I mean, I think the primary one that comes to mind is alcohol, right?
Yeah. Alcohol and cannabis. For me, cannabis is a big. Yeah. I see a lot of emergent nightmares in cannabis withdrawal. Yeah. And I think also that cannabis post-cannabis detox insomnia is a big risk for relapse back to cannabis use.
Yeah, I think nowadays when people talk about cannabis withdrawal, they talk about having two distinct phases, and the insomnia emotional dysregulation phase can go on for weeks.
Yeah, it can. Yeah. And so I think it's entirely reasonable to give people some form of help during that time. And as you say, relying on antihistamines or inverse agonists of histamine and antidepressants and antipsychotics. Oh, we're still having that argument, are we? All right, forgive me. All right, moving swiftly on. Moving swiftly on. Let's talk about slow wave sleep. So what's the function of slow wave sleep? Deep sleep, as you've otherwise referred to it.
Well, during deep sleep is when the body is when the brain's, I want to say glial system, but I think that's the
lymphatic system.
The glymphatic system is cleaning itself. So it's really important. It's really associated. Difficulties with deep sleep are really associated with high levels of stress, but also when people develop sort of cognitive disorders. There's very interesting sort of interventions trying to increase deep sleep in people with sort of with dementias.
Yeah.
So essentially, it's when the brain is healing itself.
It's repair and restoration, and it's the garbage cleaner. The garbos go around at night in Melbourne, cleaning up Melbourne. And so too does the garbage system work in our brains at night during deep sleep. And if you don't get rid of the garbage, things just clog up. Um, Margaret Thatcher and Ronald Reagan both famously said that they only needed 4 hours sleep a night, but they both famously died of Alzheimer's disease. So when people say to me, "Oh, I don't need sleep," I just think, well, there may be very, very few people who are genetically really don't, but I'm not going to argue with that fact. But I know that the vast majority of people need 7 to 9 hours of good sleep, including a healthy dose of restorative slow wave sleep. What drugs impact slow wave sleep? Do certain drugs increase it and certain drugs decrease it?
Yeah, look, in general, again, all of them, and I will give ketamine a pass again, are not going to be good for your slow wave sleep. Right? Certain sort of hypnotics can increase slow wave sleep percentage during intoxication, but that's what goes up comes down. And when you get to a withdrawal phase, it's going to make it worse. So I'm going to go out and say it's just not good.
I think it has to be more nuanced than that. Alcohol, GHB, cannabis, they increase slow wave sleep. And I think we need to understand certainly that with GHB, people use GHB to augment the slow wave sleep, not per se to augment slow wave sleep itself, but to actually benefit from the growth hormone effects during slow wave sleep. So it's used by bodybuilders. GHB is used by bodybuilders sometimes to increase their growth hormone because it does augment slow wave sleep. So I think you need to address that issue as well, especially in someone who's misusing drugs for body dysmorphia or for bodybuilding. Um, but there are drugs that so the sedatives increase slow wave sleep. Are there drugs that decrease slow wave sleep?
I would imagine that the
Well, I suppose the
stimulants make
stimulants,
it worse.
yeah,
Yeah, nicotine,
yeah,
cannabis, cocaine.
yeah. All right, all right. According to your table, Rich, cannabis
Yeah,
increases slow wave sleep. So
yeah. So
really, it's
that's how you
basically a
look at it.
function. It's basically all the sedatives increase it, all the stimulants
Yeah,
decrease it, but
yeah.
also serotonin antidepressants increase slow wave sleep, but they decrease REM sleep.
I get fuck all slow wave sleep at night. My watch told
Why?
me I got half an hour, even though I slept for 8 hours last night.
Yeah.
Don't know what to make of that, but it's quite worrying.
All right. We'll go back. Right. So in summary, I think what we've agreed is that the sedatives decrease. Sorry, the sedatives increase the amount of slow
Increase.
wave sleep. But what drugs do you think decrease the amount of slow wave sleep?
So stimulants, stimulant intoxication, I would imagine increases slow wave, decreases slow wave
Yeah.
sleep. I beg your pardon. So there's
Yeah.
nicotine,
And also,
caffeine.
yeah. And really, withdrawal from sedatives will also decrease slow wave sleep.
Yeah.
Yeah. Yeah.
So
That's an
not to
easy.
be too much of a Poindexter, but it is exactly what I said at the start, that there are certain drugs that will increase your slow wave sleep. But I don't want to. I know you phrased this conversation like you were correcting me, but it feels like it's exactly what I initially said.
Forgive me, Richard. By the way, what's a Poindexter?
Poindexter is like a '90s term for a nerd that's really out of I don't know, like sort of a Simpsons, like '90s Simpsons. Poindexter is sort of, I don't know.
All
Maybe a
right.
listener, when they're writing in to explain why I was wrong about metazapine, can write in and explain what a Poindexter means.
All right. Okay. All right. What about therapeutic drugs? Like, for instance, SSRI antidepressants. What do you reckon that has on the slow wave sleep?
So SSRIs increase slow wave sleep, and they
Yeah.
decrease REM sleep. And so I think it gets back to, when it comes to sleep, there's no medication out there that we have that is a sleep fixer. It's just, there's talk about these orexin agonists, maybe, but there's nothing out there that you can prescribe that's not going to fundamentally change sleep architecture.
Yeah. So really, there is no panacea, as you've said. There's no magic pill that's going to restore sleep, all elements and all phases of sleep. And really, I think the best thing is actually to look at sleep hygiene, which is perhaps a talk for another day. But in the meantime, Richard, I really want to thank you for your expertise today, and look forward to chatting with you again soon.
Thank you very much for having me on, Fergal.
That's all for today, folks. My name is Dr. Fergal Armstrong, and this has been Cracking Addiction.